Good evening and welcome to my State of Mind. I am Dan Yorke. It's a fluid situation with our hospitals right now, with overflow plans for the Citizens Bank alternative site and perhaps still the convention center. The administrators of the two major hospital groups will have much to do with how this comes out. And we're recording this broadcast midday Monday. The governor may have actually said something about that in the last day or two. So everything is in context. But truth be told, there's a bigger picture about the virus, the care, the hospital approach, and all of that. And no better to speak about it than the CEO of Care New England, Dr. Jim Fanale, who you'll meet right after Tim's update from the weekend.
Hospital diversions don't mean an ER is closed. They still accept patients who can get there by themselves, but an urgent trip in an ambulance may take longer when the closest hospital is not an option. This Providence Fire Department dispatch call has been happening more and more in recent months.
Is Rhode Island Hospital open and accepting?
Negatives are on diversion.
Target 12 reviewed ambulance diversion data from the Department of Health, which shows in August, the yellow line, there was an 82% increase in diversions compared to the same time last year. A trend the state's head of the American College of Emergency Physicians says is because hospitals are taking in more regular patients than they did in the spring.
We're seeing not only high numbers of COVID patients, but high numbers of every type of other patient that comes in.
We don't like to divert. Doesn't help the community we serve.
Dr. James Fanale, the president and CEO of Care New England, says staffing and nursing home reluctance to accept patients discharged from the hospital have strained the system. But he does not think elective surgery should be put on hold like they were in the spring.
If we shut down if we shut down surgery center, it's going to put your hospitals in financial peril that we may never come back again.
Governor Gina Raimondo, who would ultimately make that call, agrees.
So no, the plan would be to allow them to continue their business. Frankly, the hospitals will go out of business if we don't allow that. And so the plan would be to use the field hospitals instead.
Fanale says he thinks they are easing the bottleneck because he has been able to increase staffing.
But we are endeavoring to try to cut that to zero every day. I think you'll see a dramatic change from November 8th on.
Raimondo says the plan to dismantle the field hospital at the convention center is on hold as cases are on the rise, leaving 2 field hospitals in the state. But Fanale expressed concern about the ability to staff those if they were activated. With the Target 12 investigators, Tim White, 12 News.
And so with that briefing from last week from Tim, we bring you Dr. Jim Fanale, who is the boss at Care New England. Doc, long time no speak. How's it going?
I think it's going as well as can be expected. Lots of things going on. I mean, the COVID thing, the lifespan thing, et cetera. So I would say there's not a moment there isn't something going on. So pretty busy.
Yeah, your frontline workers are heroes in this situation, right up to this to the boss, right up to the CEO, right, are now on a full court press. We knew that we were going to get into this cycle. I mean, it's not as if we didn't hear about second wave early on, right? But for some reason, I don't know, it's come on not as a wave, but a tsunami, it feels like. And should we be surprised? Were we hopefully ill-prepared? Is it not as big as it's made out to be? Give me your perspective on that.
Yeah, I think that we had a little blip in the summer where people got a little taste that it might go up. But I think people felt pretty comfortable when things sort of dissipated immensely over the summer. I think everybody knew the likelihood of it coming back when, it's starting to get cold outside, people go inside. I think it came on a bit more quickly than we anticipated. I mean, we went from, just using Kent as an example, which is not a huge hospital, we went from, I'd say 10 patients to 35 almost in like 2 weeks, okay? It hasn't overwhelmed us, but I think it came on very quickly. The second thing is the exposures are getting a bit more prevalent. So our healthcare workers are getting more exposed. Is it a natural phenomenon? Maybe. But I also think the distancing and masking, although people try to do better, I don't think they did as much as they could. So you always keep hearing these stories about these big gatherings of folks coming together, which is probably utter stupidity, quite frankly. And that fuels more spread. So I think it came on a little more quickly. It is real. It's absolutely real. And when on Friday, I've got 50 patients at Kent when I never had that many before with the disease or suspected a disease. It's a big thing.
Yeah. So, yeah, I think people have a little bit of a misunderstanding about how this thing grows on us. The virus itself is what? It's like, water leaking. It's just going to find every place that it gets an opportunity to run, it'll run. Is the and I listen, I know you're not a biologist, and I it's not maybe your specialty, but what are your experts telling you about the nature of the virus and how it expands, or whether it's just static and flowing because of behavior and person-to-person contact? In other words, is the virulency of this thing changing one way or the other? And where do you equate the behavior and the nature of the virus?
Yeah, I think, and again, I'm not an epidemiologist or infectious disease expert, but I know a few things. I think the virulence is like, maybe it's worse than influenza, which we get every year, but we've kind of ignored it. It is more virulent. I think the other thing is a lot is unknown. And so as we've gone through from the early part of the year to now, so the incubation period is longer. And I think the frightening thing is you could get a COVID test today, be negative, you could still be positive because the incubation period is such a long incubation period. I think the other thing is that with the testing, there's a lot of the rapid testing that I don't think is as accurate as the PCR testing that we do to validate. And so that's another thing. The testing hasn't caught up with all the work that needs to be done. So third, I think people are still very, very scared about the death rate of this thing, which was quite impressive in the spring. I think it's gotten less so now. And fourth, we actually, in the evolution of this thing, we actually have some treatments that are actually starting to work. So I think a lot has changed since March, for sure. From March, it's remarkable. You got a virus, didn't know anything about it. Now you know a lot about it. Now you know you have some things that work. It spreads. And I don't think people know exactly everything they need to know about it yet.
What's the average stay time for a successful treatment for somebody that ends up in the hospital? You go to the hospital because your doctor says, all right, listen, the breathing, blah, 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 da, 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 or someone panics and just says, that's it, I got to go. I'm guessing that happens from two different directions, right? Can you get to the hospital without a doctor sending you there?
Yes. I think a lot of people are coming into the emergency room with respiratory complaints. And people with significant respiratory complaints will get admitted, because that's the frightening piece. It's the respiratory disease and pneumonias. Those are the things that cause the most morbidity and mortality. So I don't have data on the length of stay, but we knew remdesivir and dexamethasone, the treatments, that's the high dose steroid and the antiviral. We know that's shortened the length of stay in the initial cohorts. So we know that's happened. Interesting enough. So I think that's what's happened. I think that people are coming because there's a treatment now. Remember, in the spring, we had nothing to work. People were, you had the president going around saying everybody should take hydroxychloroquine. Remember, I told you it wouldn't work. I was right that time. But so I think the treatments are there. People with respiratory symptoms, they qualify it. It's an inpatient treatment. It's 5 days of antivirals and dexamethasone. So maybe we're treating people earlier, so the length of stay will be less than it was before.
Okay. When we come back, we'll talk about what the reality is in terms of manpower, person power, the field hospital ideas. Again, as we tape this show on Monday morning, and you're seeing it Tuesday night, some things may have grown in terms of facilities. Dr. Jim Fanale is the boss of Care New England, and we'll be right back. Stay with us on My State of Mind. Welcome back with Dr. Jim Fanale. He is the boss at Care New England. All right, so this is a very fluid situation. Last week, the governor talked about the field hospital. Right now, it seems as if the convention center is still immobilized, but the Citizens Bank building that is now, $35 million and always been ready to go is likely to be used. That seems like it's going to be under the Care New England auspice, so you know a lot about that. The governor said one thing last week about what its potential use was. You and the boss at Lifespan had some other brainstorm thoughts, even on the radio last week. Tim Babineau, of course, your peer at Lifespan. And even today, we're a little mixed up. So I'm hoping we're not obsolete on Tuesday night from a Monday morning conversation. But what's your perspective on A, will that be used? And B, what use will it actually provide?
So I think the potential use of the Cranston site, as well as perhaps the convention center, because that's under discussion as well, given the locations of the two units, given the predominance of patients in the Providence arena as well as the Warwick patients, I wouldn't be surprised if both open. And I think the use will be for, again, patients who are at the end of their stay that have received acute treatment in the hospitals, and they could spend the last few days recuperating in this alternate site. The important thing about that is we have patients that are sitting in beds in acute care facilities, especially at Lifespan and Kent, where patients are not able to be discharged. If they could be discharged, we'd have more available beds for the acuteness of the situation. So I know that Dr. Babineau last week mentioned they've got 50 to 60 patients sitting at Miriam or Rhode Island that don't need to be there. We probably got 20 or more at Kent. And if you could get those patients to relieve, that safety valve allows you to care for more positive patients. So our thoughts are it would be a step down kind of a unit where the most important thing is safety. We don't want really, really sick people in those places, but we could take care of them very well in an alternate site with a different care model. So my sense is there's probably a pretty good chance, as we worked over the weekend with some of the governor's staff as well as Lifespan and Care New England, looking at what's the right size of these units. Should we have both of them open? And I think it could be used for that kind of population. There's another utility that we're working on is, you know, that this monoclonal antibody treatment received emergency use authorization. So that's for a cohort of patients that are ambulatory, not admitted to the hospital, that are COVID positive. Most of us have infusion rooms, have patients that have rheumatoid disease or cancers, and you're giving them, you know, high dose chemotherapy, other drugs. You probably don't want COVID positive patients mixed in. I mean, you don't. I'm being somewhat facetious. So this is an alternate site where we can segregate that infusion room way off to the end of the site, and maybe we can use it, that site for monoclonal antibody treatment, because it's tough to do it on site where we do it now.
Okay, so the antibody thing it feels like it's brand new and good news. Is this another step up in what we've dreamed about? You know, we've been dreaming about vaccine, and we'll talk about that in our next segment. But we've been dreaming about a Z-Pack. You know, something correlative to you've got it. Don't worry, 5 days you'll be better. Is that what this antibody treatment is?
My sense is that, you know, Z-Packs for a number of diseases shortens the course of the disease. They may not cure it. The monoclonal antibody shortens the course of disease. So yeah, I think it's another treatment modality that will help people who have symptomatic COVID disease, not asymptomatic, that you're going to treat. They don't need, so you got people COVID positive, no symptoms. You have people COVID positive symptoms, and you have hospitalized folks. So I think it's a middle cohort that would be qualified for this treatment. And I know that the state's going to distribute these doses of that treatment, but we got to be able to give it effect. It's an intravenous infusion. Takes an hour to give, and you got to watch people for 6 hours because you're trying to watch for any kind of allergic reaction to the antibody treatment. So it's a 7 to 8 hour treatment, right? So you got to have a site to do that for each patient. But yeah, it's another weapon.
And how? I mean, what do you foresee? I mean, hundreds of people at a clip getting this? I mean, what's the capacity for the treatment?
Don't know. What I do know is the state has a few hundred doses initially. And those doses will be distributed to the sites that can provide that. But it's got to be provided. So I know there'll be patients that qualify, and I would bet you there's more than 300 probably over the course of the next couple of months, right? But how that's going to be done, and we know how to give the infusion, we know how to do it safely. We got to find a site to do it safely.
Do we have enough antibody material to sustain the wave? I mean, is it coming? And I'm guessing the antibody is coming from sick people who have contributed to the cause here.
Yeah, my understanding is that the state has access to 300 doses. That's what I know. And I can't substantiate that. That's what I've heard. And it should be done. It should be managed by the state in terms of how they're going to dispense this, just like that's with the vaccine, which we'll talk about in a few. So I think what they're going to say is, here's the cohort of patients that qualify, my sense. make sure you got the process to distribute it. And you got to make sure when the patients come that they do qualify for that treatment. You don't want to use it on people that don't qualify. So it's too soon to tell if this is enough or how much more. I don't know that.
But this is something, once the state puts a plan together, you will execute, correct?
Yeah, we think within a week. Yeah, I think that we will put the process together. I know Dr. Babineau and Lifespan is looking at how they might be able to do it. I mean, they have a large cohort of patients. We have a large cohort of patients in terms of a large primary care practice sites. So they fill the criteria, they should be eligible. And then I think it's probably first come, first serve.
All right, on the vaccine with Dr. Fanale when we come back. Stay with us. Welcome back with Dr. Jim Fanale, the Care New England boss here. So look, Moderna comes out and says they think they're 95%. Pfizer is at 90%. Early on, we were hoping for what, 50, 60%.
Yeah.
Do those numbers come down, you think, over time? Or is this the kind of efficacy that we can actually count on with this vaccine?
Yeah, so not being a virologist, I'll give you my clinical sense is that, I think the study's in a smaller cohort of patients. Will it mollify and go down somewhat? Perhaps, but I think 90, 95 should be extremely encouraging to just about everybody. That you got a vaccine that looks like in the short-term studies is pretty effective. Now they're going to go get their emergency use authorizations, the EUAs, and then you got to figure out, remember, some of the problems is which vaccine is a 2-dose vaccine, which one has to be frozen versus refrigerated. Now we have to have the capacity to be able to do that. So it's very encouraging, I think, and I even think Dr. Fauci has said by the springtime where you could be vaccinating hordes and hordes of people. Again, the process, I think, in the state will be that the Department of Health will get access to a certain number of doses of vaccine, and then there will be a distribution process. We may have access at our hospitals for 1,000 per hospital or so. And how do you do that? And remember, the next question, Dan, is are people going to be comfortable getting it or not? I think with the Pfizers and the Modernas of the world have come out publicly a month ago and said, listen, it's going to be based on the science. This is not a political vaccine. So I think people should understand that the science is going to be there that says this will work. This is how it should be done. And then we're going to have to prioritize probably the healthcare workers, nursing homes, and older folks first.
Yeah, the politics, and when we haven't even touched on the politics, we might as well not even. The only thing that worries me really significantly about the politics when it comes to your job is the transition and Joe Biden's people, working off the same page as Donald Trump's people, because Donald Trump's there till January 20th by Constitution. That's worrisome. Governor Cuomo was saying, hey, listen, don't start the Trump plan because the Biden plan can't unwind the Trump plan, and distribution through hospitals and pharmacies is not exactly what we want to do here. But I'm not sure what his thought process is. You're shaking your head. What's your thought about the politics of the distribution of this whole thing?
I mean, this cannot get in the way. I mean, cooler heads got to prevail. I mean, we've got to do what's right for the country, what's right for our patients. But I'm hoping that the Trump camp, the Biden camp can get this thing going together. Because you're right, the current president's in office till January 20th. And please start the transition so we can make sure that our patients are taken care of well.
Yeah, I mean, these are crucial 8-10 weeks right now. I mean, the politics and, national security, foreign policy, stimulus, all of which are important, could probably get to January 20th without solutions.
This
thing can't wait to January 20th without solution, correct?
I think that's right. And I'm going to assume that given who we are, that we will rise above it and make sure it doesn't impede the implementation of the vaccine. Because that's what we got to hope for and have cooler heads prevail.
All right, I only have a couple minutes. What is your what's your overall? I mean, you've been very, very, I wouldn't say stoic, but very calming influence on this conversation in all your public visits with everybody. I've never felt you push a panic button. I think you were very practical about your discussion about it in the spring. Where are we versus that? Where are we now? Where are we going to be by this spring? Are you bullish on us getting back to any kind of normal?
I am. First off, been doing this stuff as long as I have been. You've seen just about everything. There's no more of an emergent problem than taking care of a very sick patient, dealing with family when a crisis occurs. And that stuff's emotionally challenging. And this stuff is sort of an offshoot of that. So having done enough of that in the past and being in emergency situations, I remember being as a medical student, a nursing home fire down the street at the emergency room I was working. That was my first calamity. So I think calm is important. Our community and our citizens and everybody has to know we got a handle on this. I think we do. I mean, I think that especially with our lifespan, it's not working together to try to do the right thing together to take care of as many people as we can to get the right result. So I'm encouraged. I'm confident we're going to get through it because we always have. We've got to be calm, okay? There are more patients. We can handle it. We can take care of our patients that are sick with other illnesses. We can do it. We do it well. It's safe. There's a little trust that needs to go on that we can actually pull this off. And I think we can because we're going to do science-based, practical-based, and we contingency plan for everything. I've always been a contingency planner. You always got to think 2 steps ahead. What happens if this doesn't work? What happens if that doesn't work? And if you do that, patients will be safe and they need to be confident that their leaders can do this.
All right. Well, listen, mergers and other stuff. And look, the good thing is you and Lifespan have found a way to coordinate. It's probably going to work out that you find a way to marry each other down the line. We'll talk about that in our next session.
That's right.
It's good to know that you feel that way, and we'll just one step at a time. But the theme for Thanksgiving is slow it down.
Thanksgiving is you got family, take care of your family, be good to them, enjoy Thanksgiving, and we'll get through this.
All right. Final word, and we come back. Stay with us. Obviously, this remains a very fluid situation, and we'll do our best to stay in touch with it. Our schedule is for tomorrow night for you to meet the new Speaker-elect of the House of Representatives, Joe Shekarchi. So be tuned for that. And on the radio, weekdays 3 till 6 on WPRO. Good night.